Well, with that said, that's the good prompt to explain why we asked Dr. Elkin to speak with us today. For those of you that are not familiar, my name is Jill Suzak. I'm the Associate Vice President, and I work for Dr. Bashir in the Office of the Vice President for Health Sciences. Um, when a number of opportunities have come out to basically look at data as related to our health systems and from a research vantage. Dr. Elkin's team, and not only his team, but his experiences are the perfect resource here at the university. So I stalked him down at a party and said, "Hey, can you do this?" And he agreed, and he said, "Absolutely." Um, he has great skills in this area. He has tremendous experiences and also success in this area. And so we thought that when NIA put out an opportunity to potentially find funding as related to aging, he was the perfect person to go to. And he has a tremendous team that he's backed up by, and he's been a tremendous collaborator across campus. Dr. Elkin, you've been funded for a wild number of years and a wild number of projects and have been a tremendous collaborator to not only people at the university, but beyond. So I toss it off to you and say thank you for taking the time to do this. And then Dr. Elkin and I, at the end of his talk and whatever his team are contributing, we have an opportunity to potentially find some seed funding opportunities in the space. And he and I can discuss that a little bit more. But Dr. Elkin, thank you for doing this.
Thank you, Joe, for that very, very kind introduction, and thank you all for coming. I'm just going to share my screen, make sure that I can do that here, and put it on presentation mode. All right, is everybody seeing my screen okay?
Perfect.
See the two thumbs up. That's great. So, as Jill had alluded, that NIA has created an opportunity, and they did it because what they really want to do is make further use of a number of different projects that are synergistically ready to be linked together to allow people to do research that they couldn't have done from any one of these cohorts. And I'm up here speaking, but I'm backed up by Dr. Melissa Resnick and Dr. Skylar Resendez from my team, who helped greatly in putting this together. So the idea is that we're going to utilize the data linkage program to request funding from NIA. And they are interested in doing this. So this is a real opportunity. They've actually put out a notice stating that they were this was an important part of their strategic planning. So they're one of 27 centers, and institutes at the NIH, and their mission is to understand the nature of aging and extend the healthy, active years of life that people have. And they have a particular focus on dementia and Alzheimer's disease, but they're by no means limited to that. And I know people think of them that way. And I'm here to tell you that it doesn't take 80 years to do aging research. And so this is actually a very fruitful area to get into, and it's under-researched in a very significant way. We have very poor treatments for Alzheimer's. I'll just make that statement right up front. And that we have poor methods for caring for dementia patients, and we need to do better. But in addition to that, the basic mechanisms of developing and progressing aging are relevant to almost all disease that we see today. When you talk about age-related diseases, most of our chronic diseases are age-related. And so I think this is going to be a fun area of pursuit. I hope I get you interested in it. So the data linkage program, are called Linkage. It's with their mission in mind. They created this program in 2021. It was formerly known as Medicare and Medicaid Resource Information Center, MEDRIC. And it contains both raw and curated logical data sets, longitudinal data sets that provide data regarding hospital stays, doctor services, prescription drugs, both from Medicare, Medicaid, and from curated study data. That this program offers a unique and valuable opportunity to obtain grants and to perform studies that you couldn't otherwise. It currently includes 17 study data sets that we've categorized into sections that I'm going to talk about. The first is studies concerning specific diseases and disorders, and you can see the number of them next to them. Cognitive, behavioral, and social studies, physical and mental health studies, and one miscellaneous category, which we'll talk about because it's interesting. And this is an enclave that they've created at NIA where you get onto the enclave and can do all your data analysis and linkage there. You don't have to have the equipment here. You don't have to buy software. You don't have to, do anything but learn the system and to get onto it and get approval. Their platform offers a secure, easy to navigate, and remotely accessible statistical analysis environment that meets federal data security requirements for protecting personal health, identifiable and personal health information. Users will have access to, depending on what software you like, SAS, Stata, R, Python, MS Office applications, and they've put other miscellaneous things on there too. Users can also receive data analytics and technical support from CMS data analytics experts that are associated with NIA. So you must either be approved as a study or as a researcher. If you want to be included as a study, you follow the following guidelines. And we put this QR code up there. I'm going to leave this for a second. Get your phones out and just go to the site. It's easier than copying that longer URL, but it's the same thing. This includes having an active NIA grant award with at least one cohort and committing to share your linked data sets with researchers, either at the time that you join or at a future date. So if you're applying for a grant, that counts. Okay? What they want to do is make more of what they've put into in terms of funding. So if you're a NIH institute or center, you want to have the most impact you can and be able to demonstrate that to Congress and to Building 1, the people who run the NIH. And so it's incented that they make as much as they can out of the money they've already spent. This is a way for them to extend the work that they've already funded and to create opportunities for new projects that are data driven, that can be supportive of their overall goals and themes. So study guidelines for joining the Linkage program are you must meet the following criteria. Demonstrate that you're affiliated with a U.S. institution and accessing data from the U.S. That's us, right? Have an active NIA award with at least one cohort or applying for one. Obtain consent or waiver of consent for the CMS data linkages. That means that you can get those data linked to the material that's been derived from the studies that they funded in NIA, and provide proof of sufficient personal identifiers to support CMS data linkages, which means that you have to be willing to keep safe the PHI that they have and keep it on their system. In point of fact, you're not taking anything off the system that has PHI. You're only taking aggregate data off the system. You commit to sharing your linked data with other researchers. So let's say you create a space on the server and you find some things that are important. At some future date, someone might build on your work and look at the work you've did and combine it with other data resources in order to find something more miraculous. Or maybe you'll come back and do it again. Or maybe you'll find other collaborators, hopefully at UB, but anywhere in the world, that are the right people in order to extend the science. So data access requesters, custodians, and compliance officers must be either U.S. residents or permanent legal residents. This is the strict NIH funding requirements anyway. And then you must adhere to the following. as a researcher, you have to demonstrate you're affiliated with our so like UB is a U.S. affiliated institution, obtain approval from the participating study to use the CMS data in your research project. And that means providing a letter and an IRB and a waiver of consent so that you can, a HIPAA waiver so that you can get access to the data. And then what you're going to do with the CMS data and the NIA funded data. So you're going to have a little bit of a write up that you have to provide. You adhere to the CMS data cell size suppression policy, which follows HIPAA. So it says, if in a particular zip code there's less than 20,000 people, then you have to change the zip codes to 3-digit zips, things like that are important for people to know if you're using CMS or any kind of HIPAA protected data. So data access researchers, custodians, compliance officers must all be U.S. citizens, permanent residents, and establish a Linkage Docs account by contacting support at linkagesupport.zendesk.com and request a research lead account. To access the data and establishing this account, you're going to contact them again. You're going to note that you can have 3 types of roles. You can be a research lead, who's the person in charge. You have research requester, who's an individual who works on a project that's requesting specific access. So your team could be a requester if you're the PI, or you could be a researcher, an individual who wants to get an NIA and can manage the NIA DUA, request packages. And I know that there are resources if you go into Click, there's a thing called agreements in there. And if you put in this DUA into the agreement under Click, then they'll assign an attorney to it in order to get that done. So by default, your role is PI, unless you tell it you're not. Okay, so you want to be PI in your own research for the most part. And for information on steps researchers can take to access NIA-funded study data once your approval has been obtained, there is a link here, and we're going to provide this, which gives you a PDF, which you can get access to, and I think we can actually post that along with the talk. So that it's available to Jill and the research community. And it shows you exactly how to do it. So, by the way, we're here. We have resources in the Department of Biomedical Informatics. And let's say you're not technical and you don't program in Python and you don't know how to do data cleaning and all that. Don't fret. We're here to help. We're here to make sure that you can do this. And we, want to be on the papers, and we want to be putting out grants with you, so we're interested in doing it. We've got a cohort of a lot of faculty and students that are at our disposal to help. So let us know how we can facilitate your interest. We also have AI, which sometimes you want to incorporate into your work. So we've got a little 30-second commercial interruption in the middle of this. And this is our AI. It's called Semantic Clinical Artificial Intelligence, pronounced SKY. And that you can put your phone up there. It'll take you immediately to the site. And we have the most accurate medical question answering software. It is completely approved by UB for teaching here at UB. So it's gone through all of the steps the North Campus wanted, and it's available to people to use. And you'll see when you go in there, you don't need to put in anything. It's completely encrypted, firewalled off, and it doesn't remember anything you put into it or what it gives you back, so you can feel pretty comfortable putting in whatever you want. It doesn't give you trouble. We do teach data science. Let's say you're not a data scientist, but you get the bug for it. Every summer, we put out a boot camp, and the QR code for the boot camp is right there, so that can get you there. We do about 28 or so lectures every summer. It's the beginning of all the training for the clinical informatics fellows in the country, for all the people in the CTSA consortium, for all the people that are associated with the VA or the NLM training grants. All of them take it. We had 743 people last year take the course. and it's growing popularity every year. We had 191 government people take it, so you'll see people in your class that from all the institutes and centers, and there's we keep adding content every year. So if you're interested in this area, this is a way to learn, and just the schedule from last year's up there. You can find at this site the schedule from this year, which is now posted. Okay, so now we're getting into back to your regularly scheduled program. So, studies concerning specific diseases and disorders. This is the first cohort of studies that were done. We're going to go into this one a little bit more detail than some of the others because they all follow basically the same pattern. Okay, so this is the National Dementia Workforce Study, right, which is number one of four, and it's got a tremendous amount of data in the United States. It's uh, professional dementia care information from community physicians, nursing home staff, assisted living staff, home care staff, and you can see it's just a ton of data. And basically, the data sets come with inclusion exclusion criteria that shows you exactly who was included and who was excluded from the study, and gives you the final number at the bottom right corner here that's in the data set, which is 492,183 patients. And it can tell you exactly the workflow they went through to get the final questionnaire to fill out the data set. Data types included beneficiary demographics, enrollment, coverage data. So you're getting linked, and you get all their Medicare, Medicaid data, which is also useful. Outpatient claims, and that can be clinic visits, emergency department visits, observation stays, and fact-based procedures. And then they had carrier data, they had claims, professional services, they had billing, so CPT and HCPCS codes, so all the billing data for all the procedures that were done, and NPIs. Of course, doctors aren't protected by HIPAA, so they actually give you the NPIs so you know who the doctors were, so you can look at trends. We do not encourage you to compare our local hospitals with each other. This is something we made a decision at HealthyLink not to do, and it's best for our region that you don't do studies of that type. You could, but it's a little unseemly, and it's probably if we start to get competitive about data, people will have problems with what we do, and I just recommend staying away from that kind of research. Skilled nursing home facility claims, home health claims, hospice claims, durable medical equipment, that could be procedures, encounters, orders. It's quite a lot. And then diagnoses, procedures, medications, and they follow through pretty well with even dispensing information. Costs like the amount billed and cost of care for everything is in there. Provider facility data. This is a lot of really great stuff. And utilization encounters, so hospitalizations, ED visits, readmissions, service frequency, and there's some references for it if you care. And then there's assessment data, non-claims, clinical data. There's minimal data set for nursing homes, which is, I don't know if you know this minimal data set, but it's very comprehensive. The minimal data set that nursing homes have to fill out is a big reason for cost of nursing home care. So it's not, OASIS is the part of the claims in New York State that are not only covers home health but covers all addiction services. And then rehab, inpatient, and hospice care is also part of this. So quality data that's been submitted, that's voluntary, but it does get submitted. A lot of outcomes data is available through this. So, of course, for money, readmission, mortality, quality metrics tied to programs that are in CMS are there. This is really good. It's good stuff. And then, there's another one which is about CMS Part D data, which is the prescribing data insurance that you get when you get older if you don't have other insurance. And here again, you have the plan, you have the demographics, then which can have race, ethnicity, even has geographic indicators for differences between regions. You've got plan type, enrollment dates, low income subsidy status, benefit phase. Really great stuff if you're interested in health systems research, you know. The primary data set from is medications from Medicaid Part D, Medicare Part D, because it's about meds, but it has all the fill dates, you know, and the pharmacy date. You almost never get from, you know, you get doctor prescriptions, but actually filling the prescriptions, that's really choice data. And so, you know, you have total drug cost, the amount paid, out of pocket costs, manufacturer subsidies. You've got pharmacy data on how they delivered it. You've got utilization. You've got drug characteristics. I mean, it's just great. And then um, you've got Medicaid also has similar things in it. That was Medicare. This is Medicaid. Medicaid is the people who don't have much money, so they get subsidy insurance. And this is and you can have dual coverage, so you can have Medicaid, Medicare, and stuff, and so it allows for fee for service. But you can see that you get much of the same kind of information. But the OASIS data set, that's about cognitive and behavioral information, confusion, memory impairment for people who are, you know, with Alzheimer's or other dementias, anxiety and depression indicators, behavioral symptoms, pain, dyspnea, wound status, pressure ulcers that develop in these places, incontinence, fall risk. You know, almost everything you need to know about the elderly is in here. The therapy needs, utilization, physical therapy, occupational therapy, speech therapy, caregiver support, social services, safety risk, hospitalization risk, emergency care, medication management capability, care plan indicators, functional improvement, you know, that you get from the treatment that ensued, hospital readmissions, discharge, disposition, improvement in ambulation, pain, and so forth are really important. And again, with the minimum data set that you get out of the nursing homes, it's got all the active and chronic and infection disorders, the mobility, transfers, eating, toileting, personal hygiene, um, you know, and it's got treatments like oxygen therapy, IV meds, feeding tubes, restraints, rehabilitation, nutrition information, incontinence, wound care. Just really great stuff. Social and environmental factors, you know, social engagement, activity participation, isolation indicators, discharge potential, care preferences. So taking into marginal utilities, it's really great. And then, you know, advanced directives, which we all have to fill out. And it's important that you understand those patient preferences. And then you've got derived data like quality metrics like fall with injury, pressure ulcer rates, antipsychotic use, you know, which sometimes are used to control behavior, you know, and then functional decline or improvement. So here's the next study, which is long-term effects of community-based volunteer trial on lifestyle activity and risk for Alzheimer's patients. And this wants to determine whether increased social, physical, cognitive engagement leads to long-term lower risk for Alzheimer's disease, reductions in healthcare expenditures, maintain functional independence, and improve quality of life, less disability, and lower mortality. And of course, here's the workflow for this one. And we're not going to go through all the data sets in their entirety. That's just the beginning one I did because I wanted to get a sense of the depth of the data. But imagine that all of these have similar kinds of detailed data associated with them. But we'd be here for way more than an hour if I went to tell you that for every single disease project that they have. So this is the Baltimore Experience Corpse Trial, which is one of the X-Corpse trials. These were 60 and older people from the general Baltimore area who were eligible for participation and agreed to randomization. And they served at least 15 or more hours per week as a EC volunteer. The Participants had to be functionally literate at the sixth grade level and must pass a criminal background check. So the data for this is very robust. There's the Rush Alzheimer's Disease Center, which is committed to discovering better ways to diagnose, treat, and prevent Alzheimer's disease. And you can see there's imaging data, there's cell types, there's genetic and epigenetic data. So there's very robust data in here. And these are 65-year-old or older, willingness to complete this, and inclusion criteria was minority, aging, research study, older adults who were African American with or without cognitive impairment, and a Latino score study, which took Latinx or Hispanic people that had no Alzheimer's or dementia, and they followed them. And exclusion criteria were, while studies often accept individuals with mild cognitive impairment, they usually exclude those with pre-existing medical diagnosis of dementia at baseline. And then understanding the cohort effects of stroke and VCID and cognition. This was formerly called the Reasons for Geographic and Racial Differences in Stroke study. And it's an ongoing study that has a national cohort. Southerners and Black Americans had higher rates of stroke, and they're looking into it. We know some of that is missed hypertension because people of African American descent often have lower symptoms with very high blood pressures, so sometimes that's the problem. But there are other reasons as well in terms of, inherent biases in care and so forth, where people don't get treated the way they should. Understand cohort effects of stroke and cognition. For this one, you had to be 45 at old, and then identified as either black or white, and residents of the continental United States. And this was done through commercial marketing lists. And then note you couldn't have a prior history of stroke, and it looked at the first incidence of stroke. And you had to agree to be willing to be followed up by a telephone call. So the next category is cognitive, behavioral, and social studies. This is one of the larger categories, and the first trial is the ASOPS trial, or Application of Economics and Social Psychology to Improve Opioid Prescribing Safety. This is meant to discourage unnecessary opioid prescribing through the application of behavioral insights. And this is great. I can tell you personally as a doctor that if people are smart, I often use behavioral therapy well before narcotics in treating pain, and it works really, really well. I give people control over their pain, and it's been a pleasure to do it, and keeps them from becoming long-term addicted, which has a lot of secondary side effects. So they got rid of people who had cancer because obviously when you have cancer, you need narcotics. And then there's advanced cognitive training for independent and vital elderly, making people live well longer, right? Is a study that's active, still trying to get people to have better reasoning, memory, and additional processing speed. And there's both primary and secondary outcomes that are reported, including ADLs and IADLs, and their ability to drive. And then there's secondary things like mobility and quality of life and that kind of thing. And advanced cognitive training for independent and vital elderly took people with a mini mental status of 23 or more. It's a scale to 30. Sometimes 26 or lower. It can be mild cognitive impairment. And then a good vision score. 2040 is considered drivable without glasses. 2050, you probably do require some correction. And minimal dependence on hygiene, bathing, and dressing, so you're relatively independent to get into the study. And then over time, they looked at you and look at all these great outcomes that you have available. It's just marvelous. And there's the health and retirement study. So as an internist, I get to tell people about retirement all the time. The couch is your enemy if you're getting close. You want to have something to do every day and know why you're getting up in the morning. And this is you have to have a plan in order to stay healthy once you retire. And so, the 65 plus part of our population is the largest and fastest growing part of our population today. And so, for those of you who are in medicine, this is going to be a large part of the people you will see. And it's going to be more and more important that we know how to take good care of them. And so, the health and retirement study took people that are 50 to 61, starting to think about retirement, and they had a new cohort is of starting from 51 is added every 6 years. This is primarily intentionally oversampling of blacks, Hispanics, primarily Mexican Americans, and Florida residents. I guess I suppose that's people from Cuba. And then a unique characteristic of HRS sample design is that the age eligibility were for both the individuals and their spouses, regardless of age, are interviewed to check on the financial data for the household, so that everybody gets they can verify twice the data through cross validation. And there's a wealth of individual data on demographics, employment, health, well-being from both the spouse and the proband. So the Nudge Air trial is optimized electronic health record prompts with behavioral economics to improve cognitive output. And this is the design of the trial. You can see it here. I love the name. Isn't that cool? It's definitely an informatics name. An informatician did this one. So the inclusion criteria is that you're eligible if you're at least on one high-risk medicine and have been there for 180 days, and that you're 65 or greater, and if you are either taking benzodiazepine or a drug that requires a scheduled drug. And then for stage 2, it requires that the patients and their providers will also be included in the secondary analysis. And we looked at anticholinergics as well in the last 180 days. And the next study is the panel study of income dynamics. This is the longest running longitudinal household survey that measures economic and social well-being, and has allowed researchers and policy analysts to investigate the dynamicism inherent in social and behavioral processes. And you can see all of the surveys that they've done here. It's quite extensive. And there's the panel study on income dynamics. They are looking at how people's income changes over time, and the health changes that go along with it. And they also looked at they excluded people who are in the military or prison, and those are hard to get IRB approval for anyway. And temporary residents are not related because they needed follow-up. The Understanding America study, or UAS, is an in-depth portrayal of the people in the United States, including their cognitive abilities, financial views, retirement planning, and well-being. I bet there's a lot of financial analysts out there who would love to get hold of this one. And this had these inclusion criteria and exclusion criteria. And I'm not going to go into that more because we're going to run out of time. So physical and mental health studies. So for many people, it can be the most interesting. So the Lifelong Family Study is an international collaborative study of the genetics and familial components of exceptional survival, longevity, and healthy aging. One of the things I like to quote, I don't know if you guys know this one, but the longest lived people with the most people over 100 are from Okinawa, actually. And they do two things differently than we do. One, they only eat till they're 0.8 full. And the second is they have a diet that's high in phytoestrogens. It's really, really quite interesting. So they're looking at the outliers, right? So they want to see people who are very long lived, and sometimes it's just good genes, but sometimes it's behavior too, right? And so they had organized the inclusion exclusion criteria. And then there's the long term care data cooperative, which was in skilled nursing facilities in the United States that had an EMR of some kind, and they were pulling the data from their EMR in order to understand how we can make care better. And they had a tremendous amount of data. Look at all the clinical data that's here. It's absolutely magnificent, and it is something that is a big problem in the United States. I don't know if you know, but we have a long-term care crisis because we don't have enough beds. It's very expensive to care for people. Most people can't afford it. We don't often have insurance for it. It doesn't cover everything. So there's really how to make this more effective in the United States, or caring for the elderly, is really important. So midlife in the U.S., or MIDAS, was conceived by scientists from diverse fields who were interested in how physical and mental health challenges across the decades of normal adult life, and who does well and who doesn't. And you can see all of the different data types, including genetic data, that's in here. It's really lovely. And this was based on a national representative survey from 25 to 74, and people did this by calling around. And they also had siblings of the probands were also identified to participate. And the National Health and Aging Trends Study, or NHATS, was fostered research to guide efforts to reduce disability, maximize health and independent functioning, and enhance quality of life at older age. And, I don't know if you know this, but in case you don't, about 2/3 of the money we spend on health are spent toward the end of life. So this is really an important thing. And and NHATS had these inclusion and eligibility criteria, and they oversampled for black non-Hispanic people, and especially those over 80. And then there's the National Long-Term Care Study, which is a longitudinal study designed to study changes in the health and function of older Americans. And they specifically looked at Medicare people, and it was all people 65 years old or older. And they followed them till they died or were lost to follow-up. And then community and institutional populations were surveyed, and ancillary surveys were sent to caregivers and next of kin so that they could collect additional data. And they really collected it till they were 95 years old. It's really good stuff. And the Wisconsin Longitudinal Study is a long-term study that collects data on family functioning, intergenerational transfers, intergenerational relationships, life course, morbidity, mortality, physical health, mental health, and well-being. And you can see the kind of trajectories that they mapped out with this. And they had these inclusion-exclusion criteria starting at high school. It's a really great study. And then there was this one notable miscellaneous study, which is the Boston Early Adversity and Mortality Study, or BEAMS. This first data to support a comprehensive picture on the early life conditions of persons who were born in the late 19th and early 20th century and have been closely studied for most of their lives. And the cohort focused on study data focused on male participants and their siblings for female data born in the 19th and 20th centuries, mostly based in the Boston area. And that is, I know I probably took too long. Did I? No, I still left time for questions. I could have gone a little slower. I thought I was going to run out of time. I had 67 slides. But I do, I'll stop sharing, but I can go back to anything that people want and talk about it at length. But I wanted to leave time for questions because there's a significant amount of material here, and it really is something you should take advantage of. I think it's a wonderful resource.
Thank you, Dr. Elkin, for your comments. And I was giggling in the background a couple of times because I put something in the chat and said, you said something to the effect of, well, if you don't know Python, and I'm like, okay, who does?
Okay.
Um, but generally speaking, like, I think what you've done is highlight the tremendous opportunities via data sets for people if they don't have the time to conduct their own study where they can like answer a question within the resources that are already there. So, can you give us a what would you tell to somebody? What would you say to somebody in the early career trajectory saying data is there,
Yeah,
don't start from scratch,
yeah, no. So you, it, although they like to fund, people who have funding through them, in other
right?
words, they have made available funding opportunities that one can apply for to use this data. But I've been around long enough to know that even when they say they don't need preliminary data, you do better with preliminary data. So you can write a letter to the studies that you want, on this in this grid, and give them an idea of what you want to do with the data set. And if it's principled and a good design, almost always they'll say yes, and they'll give you access. I mean, I've done this with open data at NIH quite a few times. I've always been granted access, 100% of the time, because that's the point. And these people, whether they really want you to have it or not, they're telling NIH that they are providing it. That's why they got funded, because they said that they would provide the data to people once they got done with it. And so this is fulfilling their commitment for their funding. So they really is an important thing for them to do, even if they want to be the ones to do the next research with their own stuff. The truth of the matter is that you can combine that data, you know, with enrichment sets. You can take multiple data sets and combine them together to learn something you couldn't have learned from any one of the data sets alone. And that can be seen as novel and enriching what the original people had done. If you say to them that you're going to reanalyze their data and get different results than they did, they probably won't be thrilled. Although I have published papers like that in the past when my students have really wanted me to. I don't recommend that as the way forward. I honestly believe you can get access without, Richard, yeah, you can get access without being funded already. And I would do that because let's say you're thinking of putting in an application, but you can get a little preliminary data to begin with, you're much more likely to be funded, I think. And I'm on study section a lot, so I think it's a very reasonable thing to do. And and one of the things we can do is we can help up your credibility in data science if need be by joining on to some of the projects that you might want in a way that would support your goals, not take it over, just support your goals, and give our technical competencies to the application, which I think is a great thing. And that collaboration has been the hallmark of my success. And I think I've been consistently funded for I think
A long
since
time.
a long time, 30 years. I don't know, almost for 30 years, consistently funded. I think through 98. So maybe is that
You're coming up on
almost?
40.
I'm coming up on 40. No, no, it must be 30 almost. 98, I think. Yeah. Um, so, and I would say that we can help with everything from grant writing to, analyzing preliminary data to knowing how to, work on data sets that you're interested in answering some question from. And the interesting thing is there's so much data that picking the question that you want to ask is probably going to be the hardest part of this. And then we just write a letter to the different studies and say this is what we want to do with it, and we want to combine the data in this way, and we want those linkages to help us to answer a question that neither of these two data sets could have answered originally. And they'll just love that. And
So,
then they'll want to fund it once you get preliminary data and if there's more to do.
before I pitch to Dr. Waller, um, I want to mention that Dr. Elkin and I have actually we've been back and forth and we've crafted a seed funding opportunity that would allow any of you on the call or others across the university to basically pitch for initial seed funds in order to get something going, exactly like what he was just mentioning. And so I can send that out more broadly, but it's a good idea to think about it in advance. So, Dr. Waller, I'll pitch to you with
Oh,
your
and
question.
let's say thank you to Jill for doing that. That's an amazing thing, and it's putting their
Mm.
money where their mouth is at the dean's office.
No, it
We
is.
we
Well, it's
gotta.
NIA is asking for this. So,
Yeah.
we need to support our investigators to go out and do it. And you have a very talented team. So, Dr. Waller.
Sure, Dr. Elgin, appreciate the information. In fact, it's almost overwhelming. And actually, that's the basis of my question. We had our work is with what's called the Drug Burden Index, anticholinergics plus sedative hypnotics. Was originally validated in 2007. We've updated it for present day, and we believe that using the NHATS data plus the Medicare data would give us the data set to do that validation. But as I listen to you, I realize that there's more in here than what we had originally thought. And I guess my question is, what's the best way to kind of navigate through the data sets that are available to determine or to make sure that are we seeking the right data,
So
or are there other data sets that would maybe help answer our question better?
Dr. Waller, I'll just make up a scenario, use case, and then walk through it because I think that might be the easiest way to demonstrate this. So let's say you had a hypothesis that care was not evenly distributed across the country, and that because of that, outcomes were different in people who were on, substantially similar regimens, and and or that the regimens for the same exact problems were substantially different across the country. Then you could take the data set that you were thinking of, maybe combine it with the Boston data set, and that should show you whether, in Boston where there's more doctors than non-doctors, is that very different than it is in Buffalo where we don't have enough doctors. And this could be very interesting in terms of policy and how people start to do surveillance for people who are on benzodiazepines and narcotics and things that you study well. I mean, I think that those would be very interesting. And plus, you have the OASIS data, which is a particularly unique other resource here because we have the opioid treatment centers, right? So we can actually look at the impact of those versus non-OASIS cared for people in the state and even in our region if we wanted to. So there's just these wonderful questions that are really helpful in terms of not only policy but also how we deliver medical care as a profession. Did that help at all, or?
Yeah. I'm thinking, we just it's such a new experience having all of these available, and it's
Yeah.
like, okay, I don't have a good grasp of everything, and I'm trying to navigate my way through to determine. I think one of the things we wanted to start to get used to the linkage data set with a relatively straightforward, validation of a index that's already been validated. We're just updating it. And basically the methodology has already been published. We're just going to replicate that,
Okay.
and just wanted to get into it that way,
That's
and
an easy
then
thing to
move
do,
on.
but I want to challenge you to think ahead 2 steps and say, what will that be preliminary data for? So
Right.
I'd love you to know, here's the grant I really want to apply for, and then think about what the preliminary data that you would need to get that grant would be. And then let's go after the data sets that would allow us to have that preliminary data in hand after we do the analysis that would put us in a really good position to get an award.
Okay. Thank you.
And in terms of we want to hold your hand so that you don't have to feel antsy about, you know, Jill's thing about who doesn't program in Python. Okay, so we program in Python, we keep programming. No, but
It was,
my
yeah, I know. It's funny
yeah,
though.
no, it is, yeah. So, but the thing is, we don't want you to feel this will be uh, such a big time sink that it's not worth your time. We want to do is make it easy, so that the hardest part is looking at the variables you need and designing the inclusion exclusion criteria and the outcomes you want to follow. Then the data scientists can go in and actually pull that data, clean it up, and then even run the statistics, right there. And then, if you find something interesting that you hadn't really thought was the case before, we can pull on that thread.
I think at the end of the day, Dr. Elkin, based on the talents of your team and the leadership that you've exhibited on campus, is that what we're trying to do today is give people who are situated in the aging space, and there are many of them. I'm looking at the screen right now of participants, and there's Carliera and there's Nick, and people who have done really good work in the space, that there are other options for advancing their research rather than what they have traditionally done before. Um, and so, Dr. Elkin's group is accessible. They're talented, and the presentation that he did today, and I thank you very much for this, Dr. Elkin, for doing this. Um, it gives you another tool in your toolbox to understand what the potentials are. So, Nick, I'm calling people out right now. Nick Carliera or Dr. Weiss, Dr. Sachidanand, do you have anything that you want to say before we wrap up? Dr. Weiss? No? Okay. So, Dr. Elkin,
Oh,
thank you for everything that you did to
I'm
prepare
gonna
for
put
this.
I'll put my email in the chat, and if you need anything that I can be helpful with, that's how to best get me. And we'll be delivering this presentation, I think, somehow to you, and we're available
We'll
to
post it
help.
to our YouTube channel. Yeah.
Yeah, I think we already gave a copy of the presentation to your office, Joe. But
Oh,
if you
good,
don't
good,
have
good,
it,
good.
let me know and I'll get it again. Um, and listen, I hope you guys take advantage of this, and I look forward to working with anyone here. I hope you have an absolutely marvelous day, and I thank you for coming and listening to me talk about this NIH opportunity.
Thank you, Dr. Elkin.
Jill, just before we go, what is the nature of the funding surrounding this?
I will forward out to all of the attendees the RFP, but it basically encourages people to work with Dr. Elkin's
Okay.
team to pursue any sort of research opportunities based on the data sciences, specifically at NIA.